We're speaking today to Dr. Robert Rosenson, who's a professor of medicine and cardiology at the Icahn School of Medicine at Mount Sinai here in New York. Hi, Dr. Rosenson. Welcome. Thank you for being with us today.
All right. Good day, Max.
So let's start with the conference. So many of the conferences that we all attend tend to be kind of one-dimensional. They focus on a particular disease or a particular organ in cardiology and so forth. What do you think is the value of having this kind of interdisciplinary almost type of conference such as the Vatican conference?
Well, the COVID pandemic has taught us that a virus can cause illness in multiple different organs, from the lungs to the heart to the brain to the kidneys to the muscles. As healthcare professionals, we need to speak to each other to better understand the underlying causes whereby COVID wreaks havoc in the body. In addition to the medical professionals, the support of the community in observing the precautions that are needed to protect others is critically important. Many people suffer. There's been tremendous loss with family members, friends, there's isolation. The spiritual aspects of well-being are clearly important in this condition.
And that's what we're able to bring together, I think, at this kind of a conference. It's so important to cross all of those boundaries. Let's talk cardiology now. Your sweet spot there. What have we learned recently about cardiovascular disease that changed the way we approach the disease, particularly not just for treatment but also for prevention?
Well, we have some great therapies that are available to decrease the burden of cardiovascular disease, decrease pain and suffering, and improve survival. But these therapies are only as good as the involvement of the patient in their care. In other words, we need to educate our patients as to why these new therapies are so important. We need to enhance our skills in the physician-patient dialogue to bring them in as a partner so they understand why it's important, even with new therapies, to adhere to their diet, their exercise, the weight, avoid smoking. And if they have family members who smoke, to encourage them to stop, to decrease their exposure to passive cigarette smoking. It's a team effort, and that extends also to non-physician healthcare professionals, such as the registered dietitian, nutritionist, exercise physiologist, and other social support.
You know, I think that's so true. We've moved beyond the I'm sick, I go to the doctor, you make me well. It really is a team sport, as you say. Let's talk then, go a little deeper into part of this, because we've focused a lot on systemic mediators or indicators of heart disease. But the big area in research these days is inflammation, which seems to underpin so many different disease states. And in cardiovascular disease, particularly how inflammation affects the wall of the blood vessel. Talk to me about that. What have we learned about that, and what can we do about it?
Well, for many decades, we've measured circulating levels of inflammatory proteins, such as the C-reactive protein, the fibrinogen, the serum amyloid A protein. But what does this tell us about the inflammation that's mediated by certain cells, by certain tissues? It tells us very little. If we really want to understand the underlying cause of disease, we need to hone down and look at the inflammation that comes from different cell types, the interaction of those cell types with each other, and how that affects the lining of the blood vessel and hence the tissue that gets affected by these inflammatory processes.
The lining of the blood vessel seems to be a real target here then, and that's kind of what initiates what we normally think of as a atherosclerosis in a blocked blood vessel?
Yes, the lining of the blood vessel or the endothelium is that barrier. It's our Teflon coating that protects us against the insudation or the transfer of the lipoproteins into the arterial wall. And when the endothelium, the lining of the blood vessel, becomes inflamed, the cells, the inflammatory cells, are able to penetrate much easier. And so, yes, one could consider the lining of the blood vessel as that first line of defense, critically important in protecting us against the hazards of different inflammatory provocateurs.
Bob, let's talk about what has been really top of almost everybody's mind for the past year or so is COVID-19. And initially, everyone thought of that as a pulmonary disease. People were being intubated. They developed a pneumonia. But now we've learned that it has a really profound effect on the cardiovascular disease. Tell me about that. How does that happen, and how has that changed how we model our treatment for COVID-19?
Yes, well, COVID-19 is, believed to be a pneumonia-based condition, lung injury, and certainly people can suffer immensely. Their lungs can fill up with fluid, this inflammatory fluid that blocks the oxygen exchange. And after the recovery from that pneumonia, there can be a scarring process that leads to long-term disability, shortness of breath, low oxygen levels, chronic fatigue. But this inflammatory process is widespread, affecting multiple different tissues in the body. And this inflammation can be completely unregulated. This cytokine storm is what the terminology is. And these inflammatory mediators can attack the heart muscle, the lining of the blood vessels, the brain, the kidneys, the muscles. So the inflammation is widespread. What we've discovered is that there is a link between inflammation and blood clotting, that the two pathways intersect with each other. And so one of the horrible consequences of COVID-19 infection is that people develop blood clots throughout their body, not only in the legs that lead to a condition known as deep venous thrombosis, where those clots can break off and go to the lung, a pulmonary embolus, but clots that are found in the brain, in the heart muscle, the kidneys, and elsewhere. So this interaction between inflammation and blood clotting is extremely important in COVID-19.
So is anticoagulation then a key component of treatment then to prevent some of these widespread damages?
Yes, so a blood thinning approach does work, but there are consequences. There are individuals that are in the intensive care unit who have what we call end organ damage. They have an organ that's failed, severely impaired. And giving heparin as an example to those individuals is associated with a worse outcome. There are some individuals where the lungs are so leaky that the use of a blood thinner like heparin will cause bleeding into the lungs. People will drown in their own blood. So we need to develop specific approaches. And we've been able to identify, again, through this inflammation-triggered clotting mechanism, a specific inhibitor that works on that process and doesn't expose the entire body to the blood thinning effect of heparin.
Could aspirin, because it's also an anti-inflammatory and an anticoagulant, be a useful drug, particularly to prevent the so-called long COVID or long hauler syndrome?
Well, we don't feel that aspirin, which inhibits the platelets, the first site of clotting, is that effective in this process. This inflammatory mediated clotting mechanism is far more profound than aspirin can block. If you have coronary disease, which would put you at high risk for a cardiovascular event, you should continue taking aspirin, right? We want to decrease the susceptibility from the underlying disease. Aspirin is certainly beneficial in those individuals, but we really need to think in a different pathway, to decrease the clotting consequences of COVID-19.
Dr. Robert Rosenson, thank you so much. Clearly, we've learned a lot about COVID-19 and inflammation, but clearly we have a lot more to learn, and I'm sure that's what you'll be working on. Thank you for being with us today.